stick it in their mouth, under the tongue. But there's some conditions under which you might not do an oral temperature. What do you think these are? Conditions under which your patient may not have an oral temperature taken. Go to page 110, 117. What did you say? They're coughing, they're unconscious, they're less than 5, they're agitated, they're seizing, they're heavily sedated, they're on oxygen therapy, facial paralysis, page 117. They have an NG tube, 170. They have redness or sores on their mouth. Do you see that? They have an injury to the face and neck. All right? So those are the conditions under which you would not do oral temperature. Remember, we don't use mercury thermometers anymore. We are using aqua thermometers, and we like to use digital thermometers with the probe cover. The reason we might use one of these, right to rectal, close the mouth and nose. Do not put it in your body. Just look at it for me, hold a while, and read the thermometer. Read it. It's a number 11, so you can go ahead and read it. It tells you where it stops. We use these because your patient might be on installation precautions, and we might need, this is called dedicated equipment. 97.4. This diagram in your literature to show you how to read it. Each long line is one, it starts at 95, and the little lines are two more speeds. Usually we use a rectal thermometer for 97.4. Very good. Usually we use red for rectal. It's easy to remember, red for rectal. Blue or green can be used in the mouth. And we use a sheet for them if there's more than one patient. Even when we're using it for one patient, we're using a sheet to cover it. Disposable cover. You got it? If you're doing oral thermometers, temperature or rectal temperatures, what do you need to use? If you're doing oral thermometers or rectal thermometers, you need to do. If you're doing oral temperature or rectal temperature, you need to use gloves. Ooh, how did they come in here? The door was open. Sorry about that. He's on your book. He's on your book. But the garbage can is right across there. So anytime I open the door, they just come on in, which is crazy. I'm sorry about that. It's on purpose. So now you know how to read the temperature. What temperature did you tell me?
It was 97.6.
97.6. And the diagram is right here. So 1 is 2, 4, 6, 8. Do you see that?
Yes.
You see that? And the big number. So that's not so hard. Sometimes I have a really hard time with people seeing just where the line is. So this is a skill too. Do you want it back? Or are you okay? You want a different one? Do you want a sheet to practice thermometer reading? Are you okay? You sure? Because we do have skill sheet that we can have you practice reading the thermometer.
You're okay? I just wanted to make sure I did the weight.
We're gonna go in the lab.
Okay.
After this, we're gonna go in the lab and do weights. We're gonna do urine intake and output. We're gonna do Foley catheter. In the name of Jesus, it's plates. There's nothing more than what it is.
This is one.
And this one is so bothersome.
I'm going to drop it.
All right. All right. So we said we're going to do, we talked about the thermometers. We said if your patient is unconscious, if they have facial surgery, they're confused or disoriented, children under 5, you cannot do oral temperature. Okay. Facial paralysis, NG tube, injury to the face or anything like that, you cannot do oral temperature for your patient. Always tell your patient what you're going to do before you do that. Remember we said that because sometimes they have dementia and stuff like that. All right, so we looked at that, and then we're going to look at pain is the 5th vital sign. According to the Department of, we didn't do blood pressure yet, did we? We didn't do blood pressure yet. So let's do pain first, anyway. Pain is more fun than blood pressure.
Okay.
So remember we were doing initial assessments for a patient, initial observations or baseline. Remember your patient just came in, was just admitted from wherever they came from. One of the questions you do need to ask your patient is, are you having pain? Because is pain an objective or a subjective observation? Because pain is a pain is Tanisha, what is pain for you? When you're having pain, how do you feel? When you're having pain, how do you feel? Do I feel horrible?
No, not everybody pays.
There you go. Therefore, it's a subjective. Pain is a subjective. Tanisha, I know you don't understand what subjective is, but when we do it, remember our scope of practice that we need to observe, right? So objective are those things that you can prove. You observe, like you look, you hear, you feel, you smell, you touch. Right? When something is subjective, it is based on the patient's experience. The reason I ask what is pain to everybody in the class, I want you to remember pain is an individual experience and therefore it is a subjective experience. My pain is different than your pain. Yeah? Your description of pain is different than mine. And because they know that, the Department of Health, they have developed tools to quantify pain. When we quantify pain, what we're doing is making it so we all understand the level of pain that your patient is having. So they use a numeric scale, which is with 0 being no pain and 1 being, and 10 being the worst pain you can have. Where do you fall? What kind of pain are you having now? Are you a 4? Are you a 5? Right? Are you a 7? Are you a 10? Or for patients who don't understand numbers, we use a Wong-Baker faces. So if you look at diagram on page 179, diagram 7-43, there's a Wong-Baker faces, right? And the guy, no pain at all, just 10. It really, really hurt. I remember I was in the trauma unit at UMJJ when they came in to survey the scale, and the guy I was working with, one of the short guys I was working with, he actually drew tears and hair sticking up and everything, and they say, oh yes, that's it. You know, so it's really interesting because they piloted it before they published it. So it's really interesting. So that was internationally adopted as, or nationally I should say, a way to communicate pain. If I tell you my pain is a 2, to you that means what? It's really not so bad, right? If I tell you my pain is 10, it means it's excruciating. Do you understand? So when your patient tells you they're in pain, pain is first of all whatever your patient say it is. So even if your patient had an amputation and they're complaining of pain, they are having pain because it's the nerve endings and the remaining nerve endings in the amputation leg that they're having pain in. You see that? Yeah. So even though you don't see, they say they have pain in their toes and they don't have no toes, they're still having pain. So there are different kinds of pain. But so what our responsibility to our patients once they complain of pain is to do what? Report it to the nurse. One of the things you do after you report that your patient is having pain, the nurses have a responsibility to make sure the patient gets pain medication. And we now have to go back and find out, did the medication work? The nurses have shared responsibility for this too, to make sure that the pain medication, was it a 10? Did it become a 4? Did it become a 2? Did it become a 0? When we do our assessments initially, we have to find out, are you having pain? Do you normally have pain? What level of pain do you normally have? Do you see that? So later on when we go to medicate the patient and we gave them the medication that was ordered and they said, well, I'm back to my baseline. I normally have 2. Some people think it's okay. Sometimes you can't get rid of all the pain just because the patient. Tap in. Woo! Get it. Oh, here it is. Here it is. Right under the leg. So you do have to document how much relief did the patient receive. And usually, standard care to the patient must be documented within 30 minutes to 45 minutes. No more than an hour after you've received, the patient has received pain medication. You can check, right? You can check on them 15 minutes later. No, you don't. You do. This is your patient. And you have to document it. Because it means that the patient wasn't paying and nobody paid attention. But when you met the patient the first time and they told you they were having AIDS, you documented that you reported to the nurse. Then when you go back 30 minutes later and the patient said their pain is 2, you're documenting that there's some relief. If you leave it undocumented, it means you didn't pay attention to it. It's not documented, it's not done. Do you see that? So your documentation has to be followed up. And pain is one of those things that we monitor. You just don't observe and report. You're going to monitor it. Monitor means you check it now and you check it again. And you go back and check it again. You see that? What is the goal of pain management for your patients? Some people have chronic pain. But they said it's unacceptable for us not to address the patient's pain. Do you see that? Okay. So some of the questions we ask for our patient when they tell us they're having pain, can you describe it? Where did it start? What makes it start? What makes it go away? What were you doing? When you change position, does it get worse? What causes it to come on? What makes it go away? What relieves it? What works for your pain? Right? Residents may have concerns about pain management and may be resistant to asking for pain medication or having their pain managed appropriately. So some barriers to pain management. Some of the things that could create a problem so your patient doesn't get proper management for their pain. One, they may be afraid that they could become addicted to the pain medication. 2, they may feel that pain is a normal part of aging. 3, they may worry about constipation and fatigue, and that sounds like a side effect of the narcotic that we give them. Feeling that caregivers are too busy to deal with their pain. Feeling that too much pain may cause death. Do you see that? You should be patient when caring for patients with pain. Remember, pain is not a normal part of aging. In some cultures, and certainly some people feel it is not right. It's just not right for us to tell other people what's going on with us. Right? Not right for us to, an older woman to complain to a younger woman. For some cultures, for you to tell people, anybody at all, what is going on. We can't tell them the secrets. We can tell them how we feel. We can spill things. And so some people are resistant. Some people, some cultures, some elderly people are resistant to reporting they are in pain. They might not want to bother you. They might want to think you're too busy. You have too many things to do. You know, it's not important. It's normal for them to have pain. So if your patient doesn't complain of pain, what are some of the signs that could indicate that your patient is in pain? Some of the signs that could indicate that you're, and I have all this recorded here. All right? Some of the signs that could indicate that your patient is in pain. They're sweating, they're perspiring, what else? Facial expression, they're grimacing, what else? They're shaking a body part, they're holding it taut. They're not moving, they're moaning, they're grinding their teeth. Yeah? They're rocking. Splinting, right? Different things. They're moaning. Some cultures, I remember in the early days when we did L&D, you could tell who was in the labor and delivery room. You could sort of kind of tell where they come from, because some parts of the country people would scream and carry on, and some people, they were very quiet. You know what I mean? Based on their culture, based on the way they were brought up, based on who they were. Some people didn't scream at all, and some people were, oh, the roof was caving in because they were having babies. Right? Thank God for epidural. Huh?
Yeah.
So you're going to observe and report increased pain, pulse, respiration, blood pressure. So increased vital signs could be a sign that your patient is having pain. We missed that, right? Yeah. Tachycardia, swelling, respiration, increased respiration, just like we did. So Joan, she got your respiration at 29. Were you in pain? Oh my goodness, we're just messing with you, right? So increased respiration or pulse rate or blood pressure could be a sign. The temperature really shouldn't be unchanged unless there's inflammation. If there's swelling and stuff accompanying that, then they would be in pain. Are you serious? Sweating? Tightening of the jaw, squeezing the jaw shut, holding or guarding a body part, we said that, grinding the teeth, frowning, increased restlessness, agitation, change in behavior, crying, sighing, groaning, moaning, breathing heavily, rocking, pacing back and forth, repetitive movements, difficulty moving or walking. Again, you have to report pains to your nurse. Some of the things that you can do: one, report so they can get pain medication. Two, reposition the body part. Use pillows, use positioning devices. A back rub.
They say alignment correctly.
Properly aligning means to keep them in straight lines, right? So one part of the body will mirror the other. Don't fall, don't fall, don't fall. You got it? Okay. Ask if your patient would like to take a warm bath or shower, right?
Yeah.
Help them to the bathroom. Encourage slow, deep breathing. Provide a clean, calm environment for your patient. Soft music may also distract them. Be patient, gentle, caring, and responsive. You feel better if you think people care about you, don't you?
Yeah. I also found that when you do not think about the pain, you don't really feel it. Like when you have a distraction, such as music or something,
you don't really feel it. Right.
Yeah.
So they said distractions would work. One of the things they introduced to us when I was working at, I think Northwest A6B6 in your cardiothoracic step-down unit was guided imagery. It's like almost like hypnotism, where you take the patient on a trip, kind of close their eyes, and you can take it to the park. You can let them chase butterflies. You can let them imagine that they're at a beach, or you bring in pictures and soft music, and it actually take the patient out of there. One of the girls was doing it as a postgrad study in order to get her thesis, to get her to finish her thesis. So she brought it in and introduced it. It was really cool. It was a really interesting thing, and it took your mind off the stress of the day. She did it on the staff, right? The stress of your work, half an hour, 20 minutes, and then she sent us back and we were refreshed. So things like those will also work for your patient. I was just going to look at the theory of height and weight, and then hopefully, I haven't seen Miss Gordon. I don't know if she's coming. It's 7 o'clock. She probably will come in later if she does. No,
you know, like 5 o'clock, everybody's coming from work.
You want to go pee? Go pee. Yeah. This is not something that grown people should ask young people to do, right? This boy, my God. Oh, okay. I was trying here. This child is so confusing. And I feel bad for him because she can't be like that. So all these things we're doing for your patient when they're admitted. Yeah? Hmm? It is a long process. I told you. Yeah, they have a lot of questions on chapter 7.
It wasn't that bad though. Most of it was common sense.
Yes, if you pay attention, really, your patient just came in, you need to check their skin, you need to weigh them, you need to.
Because at the end of the day, like you said, if the patient has the best or something, they're going to say that you're not doing your job.
That's it.
Now you're responsible.
That's it. When they already came to you with those things, right?
Everything else was pretty chill. Chapter 8.
Chapter 8. I'm telling you, I was hoping to do it today, but not today, not tomorrow. So when we come back and start over the 8 and 9. I'm telling you over a little bit now. I don't really find anybody having any problems with chapter 10. The most important.
We're watching movies and taking a test tomorrow. I'll start chapter 8 tonight.
What?
You finished that? Wow.
we wanted to talk about blood pressure. We talked about blood pressure a couple of times already. We did talk about it when we did what? When we did chapter 4 in cardiovascular system, we said the heart is a muscular pump. It sits in the middle of your chest and it beats 50 to 100 beats per minute. And as it pumps, it generates a pressure against the wall of your artery. So blood pressure is the pressure generated by the heart as it pumps against the wall of the artery. Sorry? In the same chapter, we just went back a couple of pages because we skipped over it. We did it already in chapter 4. We just needed to review it because we're admitted. Remember, this patient is being admitted, right?
Yes.
What's interesting is that doctors prefer the electronic CT machines as opposed to the ones we've used, the regular one, the manual. So we're going to talk about the heart as a pump. As it collects blood from the lungs and the different parts of the body, it allows blood to go into the ventricle. The ventricle really pumps blood. So usually when the ventricles collect blood, it pumps it out, pushes it out against the wall of the artery, that is called systole. When it pushes the blood out, that is called systole. You got it? So it shortens and really pushes, and it creates a big pressure. When it's relaxed to collect blood, it's called diastole. So of course it makes sense that when we're pushing, the pressure generated is much more than when it is relaxed. In fact, when it's relaxed, it's collected by the hands to be relaxed. You see that? So blood pressure is the force exerted by the heart.
Is measured in fractions.
Yeah, fractions, millimeters of mercury against mercury too. Right? Blood pressure is measured in fractions. Yes, it is that force that is exerted by the heart against the wall of the arteries. Right? When it pumps, that is called systole. When it relaxes to collect blood, that is called diastole. We talked about hypertension in chapter 4. We did. Yeah. So now the only thing we have to do, normal blood pressure. What are normal values? 120 over 80. The Center for Disease Control said your blood pressure normally is 120 over 80. Our blood pressure is, when would you say your blood pressure is high? They already told us that when systolic blood pressure is 140 and diastolic is 90, we are hypertensive. So where do we have the normal lower cutoff points? Remember we said when your systolic is less than 90, we can't find peripheral causes. Similarly, we see patients decompensate when their systolic is less than 100. So for example, your patient is on antihypertensive medication, our order, standard of care, is we hold the blood pressure medicine if their systolic blood pressure is less than 100 because it's just going to go lower. Does that make sense for you? Yes. So the normal range then, when do you report to the nurse? Systolic is less than 100, diastolic is less than 60. That's the lower number in. Hypertension, 140 over 90, you're reporting to the nurses. Of course, the patients are hypertensive on antihypertensive medication, so they're 150 over 95. You're going to have to tell the nurse, but already they are on antihypertensive medication. Sometimes the medications don't work. A number of factors that can contribute to hypertension. All right, so we're going to practice. When is your patient going to have low blood pressure? Right, but what are the causes? What are some of the things that could cause them to be hypotensive? They could be on medication, so probably they're taking too much medication, probably the medication. Patients with congestive heart failure, they have normally low blood pressure because their heart has failed. The pumping has lost the ability to push that force against the wall of the arteries. Patients who are vasodilated for whatever reason, if they're septic, they have bacteremia and their blood pressure is opened up, they're going to be hypotensive. Patients who've lost a lot of fluids, and that's called hypovolemia. They're bleeding, they're dehydrated, or they're septic. Whatever it is that causes them to be hypovolemia, that means they have low volume, they're going to be hypotensive. You see that? And we already know the causes of hypertension: stress, diet, obesity, kidney disease. All those things can cause your blood pressure to be greater than 140 over 90. What we do know, though, is that we have to report. Joint Commission has so much, when they regulated that when they do, you buy medical equipment, all the medical equipment has to be set at normal parameters. So if your blood pressure machine, if when we record the blood pressure electronically, your blood pressure is less than 100, your machine is going to alarm. Should, unless we go in and manually override the alarms. These are safety measures. The heart monitor is going to be set at what? The heart monitor is going to be set at what? What are the parameters that they're going to set it at? Some medical manufacturer place. What are the parameters? What is the normal heart rate? Rate we're talking about. We're not talking about blood pressure. Blood pressure, you give me a fraction. Rate, you give me a number. Remember, pulse we said was what? Normal pulse rate again, people. 60 to 100. So your medical manufacturers now automatically have to set their parameters to 60 to 100. You see that? So if you connect the patient, the machine to the patient, and the heart rate is less than 60, and if you connect the machine to the patient and the heart rate is greater than 100, so when caregivers go in and manually override these alarms, we're talking for trouble. When we turn off these alarms, we're also asking for trouble. You agree?
Yeah.
Because those are safety measures that are put in place to alert us. See how they give you visual alerts in the book? The monitors will give you audio alerts to tell you, check this patient, something is wrong. When you go and you turn off these machines, what you're doing is leave me alone, I don't want to pay attention. And then you got to go to court to tell what happened. See what I'm saying? So that's why our machines have monitors. They have preset limits. And usually they're set to normal values. Respiration monitors set below 12 to 20. Usually we raise that limit. When I'm in the ICU, I raise it up to 26. Unless I need a patient control where the brain needs to be, and their body metabolism needs to be okay, needs to be kept at a certain level. I raise it up a little bit. If my patient is normally tachycardia and there's a reason for it, I try not to interfere with those normal levels. You see? Yeah. And what we're doing is what we just got was initial vital signs. Hello. All right, so let's do blood pressure. We said when we did blood pressure, we're going to use the radial and the brachial artery. So you guys got to get together. We got to get close. So this is just a lesson. It's a stethoscope. That's all it is. It's like an earpiece. This is a signal manometer. Come on up. Why are you so scared of me? We all got to get TV. Just observing right now. Alright. So, this is a signal manometer. It measures pressure, right? The machine has the same thing. And the most you're going to ask is, where do you put the pulse? This is how many things. It goes over the artery. It goes over the brachial artery. The first thing you're going to do is find the brachial artery. On the elbow, slide it like that. Right? Nice big pulse pound in there. You're going to put it over it. You're going to make sure it's secure. This is a Velcro, so this is easy. Hold on, that are really easy to do. It tells you in the machine to artery mark. This is Velcro. Just know where it's from. Have an idea where it's close. Let's keep it straight on your patient. Close it. This is a manometer. It measures pressure. So you just gotta put it at the same level of the heart. It's like a spark. You don't need to level in. Just drop it down. Like that. So it says eye level, and it's also at the same level of the heart, so that there will be no discrepancies in the pressure. Then you're gonna put the stethoscope. The stethoscope goes front way, in front of the elbow, in front of you, like that. Make sure it works. Find the pulse again. Put this over the pulse. Keep your finger there. And now you're gonna close it. It's a valve. You just close it away from you. usually you can do that until you inflate it until it can no longer feel the radial artery. But I'm not going to use the radial artery. I just go up to 160. And as you go up, you gradually deflate. As you deflate, you look and you listen. You hit the first bump, and that's your systolic blood pressure. When it changes or disappears, then that's your diastolic blood pressure. Blood pressure is 102/70. All right, let me clean this with some of this inside. Now let's bring down and release your people. Here, like that. Let me clean this stuff. Let's just see. When you're in the clinical area, quite often the nurses, if you're a nursing home, the nurses like to do their own vital signs, so they give you medication that are influenced by, it does influence the vital signs, so they like to do that. If you might get a machine, an electronic machine that you have to do. You got it? All right. Somebody's got to move because you're too far away.
You gotta
Come on up, baby.
Yeah, you can go here.
I'm not even sitting with you. You can sit over there. She's gonna, anybody who gets, like in the lab, the last person in the bed is the last person to fucking let it go. But you do not use your thumb, use your finger, use your index finger to find go all the way. You need to go all the way up. You can't push that, do not use your thumb. Got it? Remember I showed you, start here, sliding, press down, right? Press down. Got it? Okay. On top. Now you close it, make sure this artery is over it so you can do it. There you go. All right, now you can set it on top of it. Clean it already, you can clean it. Now put the pedestal right. One finger, not your thumb again, right. Use the left index finger. Use your left index finger. So you're going to use your right hand. The palm. You're not going to hear anything right now, so don't worry about it. Look away from you. And then squeeze to 160. It's not closed. You have to close it. The gate is not closed. This is the gate that's not closed. No. It's only on top of the palm. If you're not on the palm, you won't feel it. You got it? Yes. Okay, slowly. You see the pulsation? Do you hear anything? Yeah. Keep going down. Slowly release it. Keep listening. When it changes, that will be the last one. Okay. Wow. You push it aside. I know. It's a big, it's a girl. Okay. You want to join us, Miss Inga? Okay, yeah, this is my question. Our hands go, we can get after it. Go ahead. And you get to do it. Figure out. You gotta come up a little bit more. We're doing blood pressure. We're trying to measure systole and diastole. Wait, you want to all the way up. One of the first things you do is find the radial artery. Go to the artery straight. Right? Start on the ball, flat and press down. Start on the ball, flat and press down. All three is where. Okay. Press down. feel to the root of the muscle where it catches the zone. No? Really faint. Yeah. Kind of pretty everything. Right? No? Let's see what you can do here. Okay, put your cup over it now. Important things are keeping Thank you. All right? Yeah. Thanks, Kristen. Yeah, you can go ahead. Just put it around. Yeah, you can untangle that because you're gonna hear a lot of it's not like it. So, let's go over there. Let's go to the isn't it? Okay. Not really. 160? Mm-hmm. And slowly release it. Slowly release it. That's a good lesson. Slowly. First, please, you have to release it. Slowly. Maybe you can right here first time. Right here. One slowly. Where 118, 115. We only start for them. Right here. That's 121. Over. 1 over the that's okay. Little versus level. It's okay. So you said 121 over 6 over here. But that's okay. I mean, you don't want it to. You write it down? I think she's trying to write it down. Okay, let's see where you have to do her question. Alright, so this is your cost. This part goes into the brachial artery. Brachial artery is right here. Is that for using that arm? So Okay. Alright. Now, find the pause, slide the key and hang on the boom, slide in, press down. Go in and press down. Once you're able to come up with this, let me see if I have to use the answer you before you start. Alright? Now put a cup over it and put your signal. This one goes over to something. That puts part over the top of the. Just put a hand in it. Got it? Is that okay? Is that wonderful? Yeah, it's just that, what we talked about. You can see that this is what you're going to use to measure the pressure to the same level of heart. That goes in front of you. Turning so the air pieces are in front. Turn, no, the air pieces are in front. Just the tip. The air pieces are in front. You can't go in here, but the air piece has to go this way. This one goes in front of the phone. Go in the pump. Use your left hand and close it. Let me go up to 160. Close it. It's not closed. Okay. Stop and close it. Control your mouth. Look in there. One thing was and the last one I heard the one thing you thought it. I know, I feel it. I didn't know when you started. Yeah, when you feel it like you feel it in your own feet. When you start, I just know you want to try again? Oh, when you try it again, because you get right, you okay, perfect. Slowly release it. Slowly, 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 slowly. Yes, please. You see how 149 feels there, 149. 149? That's high. You get one more? What's this there? Don't have to leave it. 149, she said 149. Where's the state of it? Actually, okay, no, this is the one I always call. Most of them, the one not from the cost, the one the
No, this is case over by this guy, like this thing. And no music. Okay, so that's your blood pressure. System goes through here first. You're going to have to put you on the blood and light off, so you can relax and relax inside. Right? And normally you'll be. It's really, and you see the again, so you can